So if I kick off with the first question. So if they've asked if the NHS Safety Thermometer has been retired, are pressure ulcers not reported or data collected currently in the UK?
Not nationally. Not nationally, no. This is its replacement and it's been just time and development. But of course, locally, it is. And that information is constantly under scrutiny and being looked at by commissioners, the likes of CQC, etc. But no, the national overview is this model hospital. So there has been a little bit of a gap.
Yeah.
It will be coded. It will still be coded if it's documented in a patient's record. It will be coded.
So
Lovely, thank you.
The information is available. It's just in the process of being fed into the new national system.
Perfect, thank you both.
Are Scotland, Wales, Northern Ireland, Republic of Ireland going to follow the MHS? If not, do you know if there are any plans for PU monitoring each of these areas?
No, at the moment, the model health system is only for England, and the National Wound Care Strategy, who are funded by NHS England Improvement, aren't aware, as far as I understand, they're not aware of plans to expand that beyond England at the moment.
Second question from the pre-submitted list. Does the model health system also take into consideration moisture-associated skin damage?
No, but I'll elaborate on that. So
Thanks, Julie.
we all know as TVNs or nurses or health professionals dealing with skin, there's still lots of variation in differentiating between pressure ulcers and moisture-associated skin damage. At the moment, the system captures pressure ulcers. What you have to remember is that if there's moisture and pressure, then that site of damage has to be recorded as a pressure ulcer. But what it doesn't do is capture moisture-associated skin damage, and there aren't any plans to capture that nationally at the minute. It was only, it was 4 years ago, it was the first national recommendation about moisture-associated skin damage by NHS Improvement England, was that moisture damage should start to be counted in the same way. So locally, that should be being captured. And locally, really, it should not only be being captured, but it should be used to drive quality improvements. But at the minute, nationally, it's not included in the model health system.
But again, it is clinically coded.
Yeah.
So there is data capture there.
So Jeannie Donnelly has asked, how will the system ensure that data is accurate? Staff often incorrectly stage pressure damage. They also stage things that are not pressure damage, which relates to your last question. And we had a question that came in pre-submitted that said some trusts verify that category 2 pressure ulcers have been appropriately categorised before reporting and find that many have been wrongly categorised. Would you recommend this practice? So it's all around getting the right category and getting the right thing documented.
Yeah, I intimated there that is a challenge, that within one patient's set of records, be it paper or electronic, you can have many different diagnoses of skin damage, and how a coder is meant to figure out which is the accurate one. And the conversations that Angie have had over the last 5 years, aren't they?
Yeah.
Which is why 2 questions, Debbie. So I'm going to take the latter one. The latter one was,
okay.
Do you recommend verifying pressure ulcers? Nationally, it's kind of deemed to be a waste of time. Not a waste of time, but a time-consuming activity, when shouldn't your time be best spent on quality initiatives? And I intimated in the presentation that I kind of disagree with that, because we've now got a new national pressure ulcer surveillance system that is going to capture data from the records and be shared at a national level. And what has happened in the past with the safety thermometer and with clinical instances is that some organisations have been very unfairly treated in a very punitive way within their organisation and externally by commissioners who look at the data. So we want to avoid that, and we want to avoid that to prevent that situation. Now, one way of preventing those punitive measures is to give you organisations the narrative around it and say that actually the data isn't quite there yet. It might not be there for some time. The data might not accurately reflect yet. But the other key one is, as we've said, is to work with the clinical coders to make it easy for them to extract the accurate information. And that's why I say that it is useful for there to be some kind of verification note or verification document. It doesn't have to be that it's the tissue viability nurse who does it, but make it easy for the coders to be able to retrieve one piece of information about that skin damage, when in a set of notes you can have, oh my God, a whole array of diagnoses. And am I right, Angie, if staff have recorded category 2 pressure ulcer, and then another one's recorded category 3, and another one's recorded moisture damage, that as clinical coders you have to capture all of them?
It's just the highest level one.
The highest level one.
Yeah.
So we know from our experience that there's often a misdiagnosis with moisture and pressure, and the document that Angie and I developed together was a verification of pressure or moisture, because that will be the biggest crux of the problem, is that there will be misdiagnosis and miscapturing of pressure ulcers that are actually moisture associated skin damage. So it's going to escalate your pressure ulcer rate unfairly and inaccurately. So work with your coders. I think it's useful to have some kind of verification document, whether or not that means, as I say, TBN or whoever verifying it, but someone who takes responsibility for putting in the final word. So yes, you've had a skin lesion, this is what it is, so the coders can easily extract that.
Thank you. We've had a lot of questions actually that have come in around when is this going to go live?
It was planned, the pilot sites were working with the National Wound Care Strategy from September to April. So then in theory, it was kind of like a go live then. Obviously, things don't often go to plan. So where it's up to now is that the extending the pilot sites now to specialist centres, Angie, isn't it?
Yeah, it's sort of like adopting into the pilot, which is then going to become the norm. So it's been done gradually.
So it's just being rolled out to, again, a number of organisations. You can find out if your organisation is one of those. And then at some point, all I can say is in the near future, because April was always the month. So it's maybe taking a little bit longer because it's fraught with data issues. And they're what have had to be kind of ironed out and addressed, and consensus agreement on some of them. So it will certainly be in the next 6 months. It could be sooner than that. And the best way of kind of knowing where things are up to is to go in, log in, and look at your organisation, see if your organisation's participating, and see how many other organisations in your region are participating.
And I would add, as a if you're not part of the early adopters now, still start working with your clinical coding teams ahead of that, because then you start capturing that data as soon as possible.
If there are several different categories on the same patient, you have to take the highest category. We've had a question from Jeannie Donnelly. She said, what happens if a patient has multiple pressure ulcers? Is this counted as one, i.e. one episode of care?
It's captured as one pressure ulcer, and it's the highest level of pressure ulcer that we capture within that episode of care.
I'll just add in on that, because the National Wound Care Strategy provided a rationale for that. And they believe that the number of patients who have multiple sites are in the minority. So we have to remember that this is national level reporting. So they just want a feel of the bigger picture. So a relative handful of patients who develop multiple sites of category, they're not thinking that that's going to impact much on the bigger national picture.
Right, thank you. Thanks, Julie.
And we have another question. Are there codes for unstageable and deep tissue injury?
Unstageable, no. If it's unstageable, then it would go to the 0.9. But good coding data should not really rely on 0.9 data. So you should have a very low minimal number of L8 0.9s, which would be classed as your unstageables.
It does pose a very, very good question. So in theory, the unstageable and the deep tissue injury are kind of temporary categories. So if you're assessing a pressure ulcer being unstageable, then it's likely that it's going to be a minimum category 3 or at worst a category 4. If you've assessed it as deep tissue injury, then that pressure ulcer should be reviewed on a regular basis moving forward, and then at some point categorised between a 1 and 4. So they're kind of temporary categories. But of course, it does pose a challenge. This might be a question. If it wasn't a question before, Helen, someone will be typing it now. It does pose the question of what then happens when it's unstageable in my organisation, the patient then transfers to another one. What am I capturing that as? And what we now capture that as, but this is just us. It's kind of regional now, actually. So a lot of Cheshire and Merseyside do this. Is that we record it as category 3 because we know it's at least that. And the National Wound Care Strategy also advocate that, actually, because they say, again, but they're talking national level reporting, they're saying that actually nationally they believe that there's a much smaller number of category 4s than there are 3s. So there's a kind of thinking that if it's unstageable and the patient's about to move elsewhere and you want to capture it in your data, that you could record it as a minimum category 3. I don't know if that helps. Because to be fair, this type of topic, it throws actually more questions than answers. But it's something to bear in mind that the unstageable DTI kind of temporary categories should be staging them as a 2, 3 or 4. If there's still that in your organisation, you can either follow them up, but that takes quite a lot of manpower and resource to follow patients once they've moved on, or you record it as for unstageables as a 3.
Getting lots of thumbs up for answering that one. Well done, Julie. Should ward clinical staff be using ICD-10 codes now, or just tissue viability nurses in clinical coding?
Okay. I would say as long as the people at ward level are documenting what they should, then their trust's coding team should be abstracting and assigning the correct code. So I would say they don't have to write the code down. I would say document correctly and leave your coding teams to code it, because it could be that there could be then confusion if someone's put the code down and then someone has documented a different stage as to what code should be monitored. So I would say documentation is key, and let the coders assign the correct code as they go along.
I've backed that up.
Perfect, thank you.
I've backed that up, Angie. There'd be no expectation, and it wouldn't be advised that clinicians record codes in the patient record. They just have to record the accurate clinical diagnosis.
Has said, given a circumstance with counting a pressure ulcer, so if we've got a patient who has a pressure ulcer that's category 2, and then it subsequently becomes a cat 3, will that be captured in a certain period, Angie, or because of a freeze in data, or are they going to get captured as category 2 and subsequently as a 3? How would that work?
So from a coding perspective, if it's all within the one spell, so if I'm understanding the question, it's going from a 2 to a 3 within the spell, it would be captured as a 3.
Perfect. There we are. Quick one. From the two of you, is there training to allow somebody to become a trust model health system champion? Will the pilot sites be providing support to trust as they move to this new system?
I can share a link with you that you can share with everyone on the call to some. Yeah, there's a training resource to become a model health ambassador, not a champion. So your organisation will have a model health ambassador. Every NHS organisation should have one. So there's training to become a model health ambassador. If you wanted to become a model health champion, I'd suggest that would be kind of a local arrangement with your organisation. But I can certainly send the link that might have a bit more information about the role and how to become an ambassador.
Fantastic, thank you.
I'd be happy to advise anybody from a clinical coding perspective and share my experience of the pilot and the work that I've done with Julie over the years. So you can quite happily pass on my email address as well.
Oh, lovely, thank you both.
Thank you. And I guess, well, following on from Angie's comments, we've had a question here. What are your top tips, having been a pilot site for this project? What would you do differently?
Form a very good relationship with your clinical code manager.
Yeah, I'd back that up. And we've been working for a number of years together anyway. So, I mean, a lot of the work for the pilot, we were in an advantage situation because we were already capturing the data locally on local systems. But obviously, it's now moving onto a national system. So, we've just carried on working together on that and adapted our EPR record. We're a fully electronic patient record trust, so we were able to work together and change that as the pilot information was feeding through to us. So yeah, certainly working together, review the data. I mean, we've been reviewing data now that it's gone into model hospital. Julie's come to me and said, look at this, is this data right? I've produced coded data reports internally, and we were quite amazed that they matched really, weren't we, Julie? So
it's a good tip. That's a good test when you first see your organisation in model hospital. You'll have a gut feeling, or you'll know because you've got your data, whether or not that's an accurate reflection or not, and then have a conversation with your clinical coder. The other person, arrange to meet with, you can easily find out who your model health ambassador is. Ask anyone in your exec team or your director of nursing or your heads of nurses or whatever, your risk manager, they'll find out. And arrange to meet with them because they're experts in using the system. They've used it for years for lots of different things. So it's so easy for them. However, they still need to know where the system's up to and that it's not perfect yet. And that at the minute it's showing a mix of organisation acquired and present on admission. And for many tissue viability nurses, for me, that's kind of what you don't want. I don't want my exec team looking at that, thinking that that's organisational acquired pressure ulcers. When if you look at one of the views, it's showing a mix. So I could be in an organisation that has, 90% of them are present on admission, so I could be showing really high, and another organisation could just have 20% present on admission and have an organisational problem with pressure ulcers potentially. And it doesn't reflect that benchmarking. So you have to really scrutinise the data to make sure it's an accurate reflection of your organisation, and make everyone aware of that. So start talking about, don't be scared of it, start talking about it with your managers to say, it's coming, it's not quite there yet, but this is what I'm going to do. I'm going to meet with coach, I'm going to meet with our model health ambassador, I'm going to make sure that the information is an accurate reflection.